Hello and welcome to our patient-centered webinar on nasopharyngeal cancer titled The Journey of Treatment Through Survivorship. This webinar is co-sponsored by the American Head and Neck Society, which is the largest society in North America for the advancement of research and education in head and neck cancer, and the Head and Neck Cancer Alliance, which is a wonderful nonprofit organization that supports patients, survivors, and survivors of head and neck cancer with education and various other programs. Our objective today is to increase awareness of the approaches to nasopharyngeal cancer treatment and the importance of survivorship. I have to start with thanking our sponsor, Coherus, for making this webinar possible. I will introduce today's speakers by outlining the agenda. I am Alice Lin. I'm a head and neck cancer surgeon at Kaiser Permanente in Los Angeles, California, and I will give a brief introduction of the disease. Then Dr. Mark McDonald, a radiation oncologist from Emory University, will speak about the primary treatment of nasopharyngeal cancer. Next, Dr. Michelle Wang, a 3-year nasopharyngeal cancer survivor, and Brad Johnson, a long-term nasopharyngeal cancer survivor, will speak about the treatment journey and its acute and chronic side effects. Next, we will have Lisa Evangelista, an associate professor and director of speech pathology from UC Davis, speak about the management and rehabilitation of these side effects. Our last speaker will be Dr. Hugh Kong, a medical oncologist from UCSF, who will speak about the treatment of recurrent nasopharyngeal cancer. I hope the audience will feel free to use the Q&A icon to ask any questions that you may have throughout the webinar, and we will end the webinar with a live Q&A session. Here are the disclosures for the speakers. Without further ado, let's start talking about nasopharyngeal cancer. What is it? Simply, this is cancer of the back of the nose. As opposed to the front of the nose, which is the nasal cavity, the back of the nose is the nasopharynx. This area is hard to see without special instruments such as endoscopy, and this area is also close to many vital structures. It sits between the ears and is essentially under the brain and is very close to the optic nerve, which is the nerve that gives us vision. The nasopharynx is also the passageway for air from the nose to reach the rest of the throat or pharynx, and eventually through the vocal cords into the windpipe. There are different types of nasopharyngeal cancer. Type 1, the three most common types are designated by the World Health Organization. Type 1 is keratinizing squamous cell carcinoma. Keratin is the protein that's found in your skin and nails. Type 2 is non-keratinizing, and type 3 is undifferentiated or poorly differentiated. Undifferentiated or poorly differentiated means that the cancer cells look the least like normal cells. Type 3 cancers can grow rather quickly. Type 2 and 3 also tend to be related to a virus called the Epstein-Barr virus, or EBV. We'll talk more about this later. There are also rarely some lymphomas and salivary cancers that can occur here. These are very rare, but my own husband is a 10-year survivor of lymphoma of the nasopharynx. So how common is this cancer? It's actually very rare. Only about 1 in 100,000 people in the United States will get this cancer. It is, however, much more common in other parts of the world, such as Southern Asia, Northern Africa, and the Middle East. What causes this cancer? Well, experts don't really know. We know that there is a big association with the EBV, the Epstein-Barr virus, in the WHO type 2 and 3 cancers. EBV is a very common virus, the same virus that causes mononucleosis, shortly known as mono. However, in many patients with this cancer, the amount of virus is increased when the cancer is detected and decreases as the cancer is treated. Smoking, alcohol, and tobacco are also associated with this cancer. However, the relationship doesn't seem to be as strong as it is for other cancers of the head and neck. Next, there's a strong influence of diet, high in salt-cured foods, such as salted meats or fish. We also know that family history and ancestry from those high incidence parts of the world that I mentioned increase the risk of developing this cancer, and dust or smoke exposure can also increase the risk. What are the most common signs and symptoms of this cancer? Well, one of the most common signs is actually a neck mass, often painless. Because this cancer can go undetected for a while in the nasal pharynx, it has the chance to spread. The first place it generally spreads to is the lymph nodes of the neck, but it can also go to bones, lungs, and liver. There are some patients who present with nasal congestion. Ear symptoms occur because, as you can see, on either side of the nasal pharynx lies the opening of the eustachian tube. The eustachian tube is the drainage tube of the ear. When this tube is blocked, pressure can build up in the ear, and this can lead to pain or infections that don't go away. Headaches or nosebleeds are other common symptoms. Facial pain, eye pain, and vision loss are less common but possible presenting symptoms, as the feeling nerve and the optic nerve, which is the nerve that gives us vision, lie in the bone that sits just above the nasopharynx. These symptoms can actually be common in people without nasopharyngeal cancer, but it is important to see a healthcare provider if these symptoms are persistent. Once cancer is suspected, the recommendation is for a very complete workup, including a complete history and physical with an endoscopic exam of the back of the nose and biopsy. Imaging such as CT scan, MRI, and PET scan are often all needed. And in preparation for treatment, it is important to evaluate the teeth and the speech and swallowing. Because of the rarity of this cancer, it is important to find a place for treatment that has experience with this cancer, and also in a place where patients are able to be evaluated with a multidisciplinary tumor board, where radiation oncologists, medical oncologists, head and neck surgeons, and others work together to tailor the best treatment plan. Before I turn it over to Dr. McDonald to talk more about treatment, I want to show the American Cancer Society data for survival of this cancer. You can see that the survival of this cancer can be relatively high, with 82% of those with localized disease, meaning disease that is just near the back of the nose, being alive at 5 years. Once it has spread to surrounding areas such as the neck, the survival drops to 72%. But even when it has spread distantly to other areas or organs, there is still a 49% survival at 5 years. With that, I'd like to hand it over to Dr. McDonald.
Thank you, Dr. Lin. My name is Dr. Mark McDonald. I'm a radiation oncologist who specializes in the treatment of head and neck cancer. I'd like to thank everyone for joining. The management of nasopharyngeal cancer has evolved significantly over time as our tools and techniques have gotten better. And the exact details of appropriate treatment for your situation could vary. But in general, the most common approach for nasopharyngeal cancer starts with chemotherapy, followed by radiation treatment with additional chemotherapy. And this is based on a recent trial which showed superior results using this regimen, even with patients with very advanced disease. Radiation therapy is probably not something that you've heard about unless you've been diagnosed with cancer that requires radiation treatment, but it's invisible energy, and it can be delivered with X-rays or with protons, which are particles from the center of an atom. And it's delivered on equipment that might look something like this, a large machine that moves around you from several positions to deliver the therapy. It's a key component of treatment for nearly all patients with nasopharyngeal cancer. And it's given as a series of treatments, typically daily, Monday through Friday, for about 7 weeks. Like all types of cancer treatment, radiation for nasopharyngeal cancer is what we call multidisciplinary. It's a team endeavor. It requires close collaboration with multiple specialists and typically given with chemotherapy. You need a mask for radiation. It's a mesh mask that you can see through and breathe through, but it's very important for us to get you in the right position each day for treatment and remind you to hold still for accuracy. And radiation works, killing cancer cells by damaging the DNA in those cells, and it has other effects on the immune system and on the tumor blood supply. Side effects from radiation are largely related to the radiation that's given to the normal stuff. So our mantra in radiation oncology is always that we want to put the radiation where it's needed and keep it out of areas that aren't needing radiation, protect those normal tissues to reduce or avoid side effects. The side effects from radiation don't show up right away. They accumulate over the course of the 7 weeks of therapy. By far the most common side effect of head and neck treatment in general and in nasopharyngeal cancer is sore throat and difficulty swallowing. This typically develops around the third week of treatment and escalates. By the end of treatment, a lot of patients have a great deal of difficulty with swallowing. And for that, we recommend oral hygiene, baking soda rinses, soft, bland foods that slide down easier. We have magic mouthwash, a numbing liquid that numbs things up for a few minutes. And we need to use different types of pain medication. We do have recent data that shows that L-glutamine, a protein powder taken during treatment, actually helps to reduce the severity of mouth sores and the duration of time that patients need strong pain medications. There's also trial data now that shows that an oral probiotic taken during the course of treatment can reduce the duration and severity of mouth and throat sores. Taste changes are quite common from both radiation and chemotherapy. It can take some trial and error to figure out which foods are tolerable. Dry mouth and thick saliva are also common side effects, for which we emphasize staying hydrated, doing those baking soda rinses, and there are saliva substitutes and stimulants over the counter which can help. Nausea can be common. Fortunately, we have a lot of good nausea medications now to help with that. There's also data for acupressure bands. C-bands is one brand, which have been shown to help with nausea related to both chemotherapy and radiation. All of these things conspire to make maintaining your nutrition more challenging, so weight loss and dehydration can become common issues. An expert dietitian input on your nutrition is really important to help identify calorie-dense foods and supplemental nutrition sources so you can get the energy you need. Maintaining your nutrition is essential really to healing and recovery and to fighting the cancer. Radiation can cause skin redness, peeling, dryness in the area that we treat, most commonly on the neck. And your radiation oncologist will recommend specific skincare, often over-the-counter bland moisturizers, and sometimes topical steroids to help. This is a tiresome journey. And in addition to all the side effects we talk about and the importance of maintaining nutrition, sleep hygiene is super important. And addressing the stress, depression, and pain of this experience is really important to help you get through it. So again, these side effects don't happen right away. They show up in the middle of treatment and escalate. And at the end of treatment, they don't all get better the next day. But the same way that they build up over a few weeks, it takes a few weeks to see these side effects start to improve. And that recovery can vary a lot person to person due to many different factors. And a big one is nutrition. It's also important to know that radiation can have some long-term side effects and risks, things that can show up months or even years after the therapy is completed. By far, the most common long-term effect of treatment is dry mouth, and less saliva in our mouth increases our risk of cavities. We put a great deal of emphasis on the importance of regular dental care, recommend a prescription fluoride gel or toothpaste to help reduce your risk of cavities. There are over-the-counter saliva substitutes and stimulants. Acupuncture has data to help with dry mouth, and there are prescription medications available as well to help stimulate more saliva output. Low thyroid hormone is also very common. Up to 40% of patients will eventually develop low thyroid hormone. And so blood work is recommended at least once yearly to monitor that. And if it gets out of whack, it's easy to fix, but it does require a daily replacement medication. Hearing problems and nasopharyngeal cancer are also quite common. It's important to monitor your hearing to report changes so that it can be evaluated. Lymphedema is swelling, often underneath the neck or on the face, which can develop after treatment. And if it does develop, we recommend specialized physical therapy for that. Some patients can develop a painful neck stiffness or tightness, and this can show up sometimes years after treatment has been completed. Physical therapy can be very helpful for that. We also have trial data now that a cholesterol medication, pravastatin, can actually improve this phenomenon. It's called radiation fibrosis. Some patients who have painful neck spasms or tightness can benefit from Botox injections to relax those muscles. Finally, I'll mention radiation necrosis. Some patients with nasopharyngeal cancer that's gone up into the brain space, like on this picture where there's a tumor outlined in red right next to some brain, that's where the green star is. Radiation can make that cancer melt away, but sometimes a couple years after treatment, we can see some signs of radiation irritation show up in the brain. In this particular patient, it was a couple of years after treatment and these changes showed up, but weren't causing any symptoms or problems and haven't required any therapy. But if those changes are causing some symptoms or problems, they may require treatment. Unfortunately, we do have trial data specific to nasopharynx actually that shows that an IV medication called bevacizumab can help improve that swelling and symptoms in patients who need that treatment. My takeaways are that it's obviously very important that you learn about your cancer and your treatment options from reliable sources. I'm grateful to the American Head and Neck Society for putting on this symposium. And your own care team ultimately should be advising you about the specific expectations, risks, and side effects of the treatment for you, because there's a lot of individual variation. But you do want to seek out high quality care and high quality radiation. We can't take away radiation once it's given. So it's really important for us that we protect as many of the normal things as we can. We want to make sure that we're reducing and minimizing side effects by reducing and minimizing radiation of things that don't need it. If proton therapy is available in your community, that could be one good option to help reduce or avoid certain side effects. But regardless of the type of radiation that's used, we also have newer data that shows that we can make some meaningful reductions in side effects by adapting our radiation based on the response of the tumor to initial chemotherapy. And we now know that in some lower risk patients, we can reduce the area that's treated with radiation, and that's also been shown to help reduce certain side effects of therapy. Survivorship is about more than just monitoring for cancer recurrence. It includes managing these late effects of therapy and interventions that hopefully reduce the risk of new problems developing in the future. I think for all of us, it's really important to practice self-care and build healthy habits and recognize that this is a traumatic experience for many people. And anxiety, fear, depression, and emotional distress are common. And I encourage you to take advantages of resources in your community to address those issues, to help you both mentally, physically, and spiritually on your journey. And I wish you all well in that journey going forward. Thank you for joining.
Thank you, Dr. McDonald, for a very clear review on radiation and treatment. Next, I would like to introduce Dr. Michelle Wong and Brad Johnson, who are both survivors of nasopharyngeal cancer, as well as Lisa Evangelista, who is a speech and language pathologist, to lead the discussion following their testimonies.
Good evening, everyone. My name is Michelle Wan, and I'm an emergency medicine physician in Atlanta. Normally, when I am giving these lectures, I am giving lectures from the standpoint of a treating physician, but I am very happy to be here as a 3-year survivor who also happens to be a physician, just sharing my experience with nasopharyngeal cancer. First, I'd like to say thank you to the American Head and Neck Society and the Head and Neck Cancer Alliance for inviting me to participate this evening. So I'm often asked about the presentation. So how did I find out that I had nasopharyngeal cancer, such a rare disease? My presenting symptom, and really my only symptom, was a large persistent lymph node on the right side of my neck. I had no other symptoms. I at first thought this is just a lymph node. Maybe I had been ill recently, but I couldn't recall having a recent illness. And when it wouldn't go away, I decided to get it biopsied, and that did confirm the diagnosis of squamous cell cancer. And initially, the primary site was uncertain. After undergoing PET scan, MRI, and primary site biopsy, which is my primary site was a tumor at the base of my skull, it did confirm that the diagnosis was in fact stage 3B nasopharyngeal cancer. And earlier in the presentation, there was mention of not well differentiated, fast growing, and that was the type that mine was found out to be at review at Tumor Board. So let me see. So this is my first MRI. This was my MRI that was done in May of 2021. And you can see in this highlighted circle here in yellow, that sort of bright white mass, which you can see better when I compare it to the normal slide that you'll see in a second, is where my tumor was. That was my primary site. My treatment, once it was determined that I had nasopharyngeal cancer, that did have some involvement in the neck with lymphadenopathy bilaterally, which means on both sides, was chemotherapy and radiation. So I underwent 3 cycles of induction treatment with Gemzar and cisplatin, followed by 9 weeks of cisplatin and 7 weeks of concurrent proton radiation therapy. I would be remiss if I didn't also acknowledge that my very own radiation oncologist, Dr. Mark McDonald, who just gave a speech, just gave his presentation, was my proton therapy radiation oncologist, and I'm forever grateful for the excellent, wonderful care that he provided to me through my treatment. So as you can see, the previous MRI that I showed you from May of 2021 is on the left, and then my post-treatment MRI is on the right, December of 2021. So that area that's kind of filled in, that's white, that's filled in that area that on the right side is black, that was the tumor. And then post-treatment, the tumor is gone. So I had a very good outcome following chemotherapy and radiation. And those are just 7 months apart. We talked a little bit about side effects, and we'll get into more about side effects here shortly. And I like to think of these divided into initial side effects and also long-term side effects that I continue to deal with now because they are a bit different. So the initial side effects that I had from chemotherapy was, as you can expect, progressively worsening nausea and vomiting. I gradually decreased my ability to taste food, which was accompanied by naturally a loss of appetite. Kind of a severe, persistent metallic taste in my mouth is something that came later. An interesting side effect that I noticed was I would have these uncontrollable bouts of perspiration with eating food that really, I love spicy food, but even if it wasn't very spicy, I would just start to sweat uncontrollably from my scalp. And I mean, like pouring down my face. It was actually kind of funny. As the treatment progressed, I developed some fatigue. And then pancytopenia, which is a medical term for low blood counts of all of the blood cell types, which likely also contributed to some of the fatigue. I did experience some hair shedding, most pronounced at the perimeter or around the hairline. And for radiation, the initial side effects, I did develop some moderate to severe hyperpigmentation or a darker appearance of the skin secondary to radiation burns that I developed at the treatment area on my neck. And I do have some pictures that are not my most glamorous photos, but I thought it would be very important to be transparent and to share what that looked like and what I experienced during that time of radiation. I also developed muscle stiffness and some significant pain that was manageable, but painful nonetheless at the radiation treatment area of the neck. I happen to have more radiation on the right side than on the left side, so my pain on the right was greater than on the left. Radiation also did contribute to some additional fatigue. And then I had a gradual but a mild decrease in my ability to smell, which that coupled with the loss of taste just further reduced my appetite. I did develop pain with swallowing, but I have to be honest and say, the severity of the pain and swallowing that I anticipated was not nearly as much. I was very blessed and fortunate that I was still able to swallow. It wasn't until the very end that it got very, very painful. But leading up to that point, I was able to tolerate liquids, soft foods, didn't really have much trouble there until the very end. So this is a series of photos of my radiation burns. At the top right, that's just my portocath. You could see that my neck is starting to get maybe a little bit darker than the skin in the surrounding area, mild hyperpigmentation. And then the large picture on the left, and then at the bottom right, you can see where there actually developed burns that were significant, like, beyond a sunburn, pretty painful, started to peel. And I did receive radiation directly to the face as well to reach the tumor that was at the base of the skull. And so I did have some hyperpigmentation on my cheeks, and my freckles did become a bit darker. But that hyperpigmentation, as you can see, has since resolved. I was able to use skincare as recommended by my radiation oncology team to ensure that my skin healed very well, and some other products that were provided to me by friends that I have in the beauty industry to make sure that I return to my glorious state. So I'm very grateful for that as well. Some persistent side effects that I had from the chemotherapy that I still struggle with today is neuropathy in my hands and feet. They what neuropathy means is basically it's like a pins and needles sensation where you have a loss of sensation. Initially, the neuropathy in my hands was so bad that I was not able to grip a pen long enough to write. It changed my handwriting, but it's gotten significantly better. The neuropathy in my feet has been more persistently noticeable. It's changed my ability to walk in certain types of shoes, namely higher heels that I felt better and more stable walking in. I don't feel as confident in, but that has gotten better over time. Also with just, exercise and some physical therapy as well. I did develop ringing in my ear that I had to get used to. It's just a thing that I sort of live with daily. But at first, I will say that has the ability to tolerate that has improved over time. It's just gotten to where I'm just accustomed to it and it really doesn't bother me the way that it did initially. Unfortunately, I have had some significant decreased hearing that is more noticeable when I'm in a large group setting and there's a lot of background noise. But I overall, I don't have to wear hearing aids yet, and overall have been able to communicate at baseline just as well as prior to treatment. I have had some changes in balance, which I attribute to some inner ear dysfunction that developed following both the chemo and radiation. In my case, this may be unique to me. I don't think this happens to many people that have cisplatin, which is a renally metabolized or a chemotherapy that is processed by the kidneys. I donated a kidney prior to treatment, so I went into my chemotherapy with only one kidney, and therefore I did have some kidney injury resulting from my cisplatin. But again, I think for most people that enter chemotherapy with having both kidneys, kidney injury is not an extremely common thing from what I recall reading and reviewing in the literature. And my kidney function, I should say, has also improved post-treatment and slowly it's, I believe, going back to baseline. I have had some mild changes in my cognition and my auditory processing speed. So I may hear something and have a response that I'm trying to formulate and gather the words together to respond. And there has been maybe a lag time in my ability to speak as quickly. My dear husband would probably say that he might be grateful for that, but my verbal response speed has been maybe a little bit slower, but very manageable. As I mentioned before, the persistent side effect of radiation, initially I had severe hyperpigmentation and burns. Now there's just very minimal hyperpigmentation that's barely noticeable. I'd have to point it out to you for you to even notice it. I have had some eustachian tube dysfunction that was worse maybe about a year or two ago, and now I've been able to control it by just using Valsalva and just being very judicious in the use of decongestants when I start to feel increased pressure in my sinuses to make sure that it doesn't get out of hand quickly. I haven't. I have had some reduction in saliva production and mild decrease or mildly increased in dry mouth, but nothing like what was explained to me that I may experience. I've been very fortunate in that regard. I think that just may be a testament to the type of radiation that I receive with protons. But there has been a mild decrease that I have noticed. And I do have a proclivity to develop neck tension and spasms worse on the right side of my neck, which has been manageable with massage. Dry needling with physical therapy has been a great tool to keep that under control as well. So what is my life like today? So I was diagnosed in 2021. I'm now basically 3.5 years post-treatment. I do surveillance monitoring with an MRI of the face and neck twice a year. I get to see my friends at Emory, and we always have a big celebration every time I have clear scans, and we look forward to continued clear scans. I initially had to have a CT scan of the chest 2 times a year. Currently, we've backed down to once a year. I'll defer to Dr. McDonald on the cadence of how frequently we'll be doing that going forward, but that's my surveillance monitoring. I forgot to include it on here, but we also do thyroid labs once a year, I believe, and those thankfully have been normal to date. As far as my dental care, because of the changes in the salivary production, as well as exposure to radiation, we do have close monitoring for development of any mandibular bone abnormalities or my jawbone abnormalities with x-rays that my dentist takes regularly. And I do use a fluoride toothpaste, which I will continue to use in the long term. But overall, life is great. I've returned to my baseline level of energy. I believe I'm close to, if not at my previous level of fitness. The anxiety and depression, is something that kind of comes hand in hand with this diagnosis. But I've been working very hard with different modalities, full disclosure and transparency, seeking therapy for it, leaning on my faith. I have a wonderful group of friends and family that have been just fantastic support. So I would encourage anyone going through this to lean on your support system. They're there for you for this reason. Family members who have someone going through this, just know how important and how vital of a role you do play in your loved one that may be going through this. And this is kind of a continued work in progress, but suffice it to say, I'm eternally grateful. I feel great. There is hope. I did very well with my treatment, even when I wasn't sure how it was going to go. And this is a testament to the wonderful care that I received. I just thought this was a great slide to end on. This is what life is like post-treatment. My wonderful family, our 5-year-old daughter, my mom, my brother, we have moved on and, living life and celebrating every day as a new victory. And that's it. So thank you for your time.
Thank you, Michelle. Hello, everyone. I'd like to thank the American Head and Neck Society and the Head and Neck Cancer Alliance as well for having me today. It's a privilege and an honor to speak with you today as a 21+ year survivor of nasopharyngeal cancer. I like to say that I engage in conversations. I don't give presentations. And so I love seeing the notes in the chat since I can't see you all. I also prefer speaking in person as opposed to virtual. But I'm going to do my best. I do have some pictures to show in a minute, and I'm just going to warn you that I might get emotional when those pictures come up on screen. I practiced this a few times. And every time, even by myself, I've gotten emotional. And it's not what I went through. It's not the difficulties associated with it. It's the overwhelming joy and gratitude that I experience when I see faces and I see and recall experiences from what I went through at the age of 27. So so I was diagnosed, or as I like to say, I was not diagnosed at the age of 27. I went to my doctor. I called my doctor complaining of headaches, sinus pressure, a number of symptoms over a series of months. And I was basically told I was a healthy 27-year-old and that, not too much to worry about and just stop eating certain things. And then they tried giving me migraine medicines and things like that. And I did get in to see a nurse practitioner a couple of times, and then I started bleeding out of my mouth, mostly in the shower, fortunately, but sometimes in public as well. And I said, enough is enough. I insisted on seeing a doctor, and I'm going to preface this by saying my medical team and the medical professionals that I have dealt with over the last 21 years have all been exceptional. And I would say I love each and every one of them. But this particular experience doesn't speak to that. I had a doctor look at me and crack a joke, not to worry, I don't think you're going to need a headectomy, and then feel the marble-size tumors that were now in my lymph nodes and tell me I should calm down. It's not like I have cancer or anything. At which point I decided that I wasn't going to go back to that doctor and I went to an ENT. Within a very short period of time, my cancer had had advanced aggressively. Within a very short period of time, I found myself in a hospital bed. I don't know how to describe it other than kind of starting to shut down. And that's when I was told I had cancer. And I looked at the doctor and said, thank you. Finally, after months of pursuing an answer, I had an answer. 48 hours later, after MRIs and biopsy, they told me I had nasopharyngeal squamous cell carcinoma and that they weren't aware of any successful treatment protocols for this disease. No, thank you. Took about 5 days through the actions of my family to get connected with Dana-Farber in Boston, where my doctor, oncologist, Dr. Marshall Posner, was, as he put it, writing the book on how to treat these super aggressive cancers that were showing up in young people with zero risk factors. And I qualified for that. Let me pop up my pictures here. So I actually, the one in the upper left corner of the screen there, sitting in a chemo chair, this was a huge, actually, milestone for me. I had this weird experience of actually feeling better as I went into chemo, dealing with the side effects, because my cancer had spread my nasopharynx through both of my sinuses, into my lymph nodes and the back of my neck. And so it was basically like pressing my skull apart from the inside. And it was excruciatingly painful. I couldn't stand up without passing out. Other things, I wasn't eating, I wasn't drinking, I was relying on IVs for an extended period of time before they could get some of this stuff under control and get the pain under control. So for me to be sitting up in a chemo chair, that was a significant milestone. I took my early rounds of chemotherapy laying in a hospital bed. Sorry, my first round of chemotherapy laying in a hospital bed. So yes, the side effects of chemo, I had cisplatin, Taxotere, and then 5-FU, which was a drug that was administered through a pump that I had strapped to me for 5 days after my day in the chemo chair. Sorry, I lost my train of thought. Someone flashed a comment up in the chat. So very similar to what Dr. McDonald presented early on, I had 3 rounds, three-week rounds of chemotherapy. And that was followed by a week break. And then I had chemo and radiation concurrently for 4 weeks with Taxotere. I had IMRT. My radiation zone went from the top of my forehead to the base of my neck. As Dr. McDonald said, they were very, very intent on avoiding as much healthy tissue as they could, but given the I guess advanced nature of the disease and how much it had spread, that was pretty difficult for them. So I would spend 45 to 50 minutes on the table, sometimes about an hour, depending on how long it took to get me in place in the morning. And then after those 4 weeks of concurrent chemo and radiation, I had 2.5 weeks of boost radiation where I would have that protocol in the morning. Then I would go in the afternoon for another 20 to 30 minutes of boost radiation just to my nasopharynx and my right sinus. I rang the bell down there in the, sorry. I told you I was going to get emotional. On October 20th of 2003, the pictures next to that, sorry. One of my last treatments, I got some advice from a fellow patient who said, when you are done, go somewhere, just get away if you can. And so my aunt and uncle gave my then fiance, my current wife, and I their house on Cape Cod. And so we went there. Actually, the one on the far left is from the previous summer when we went earlier. But the one in the middle there is us celebrating the end of treatment. So a lot of the same side effects. I'm sorry, I'll go back to the other one. A lot of the same side effects as Michelle mentioned during treatment, long-term side effects, loss of saliva, thick saliva, dry mouth. I was told in the upper right-hand corner, you can see the patch on my stomach. I had a peg tube put in. I was told that given the intensity of the radiation and the amount of area that it was going to cover, that there was no way I'd be able to swallow throughout the entirety of my treatments. And I took that as a challenge. And some days I only got down a couple of spoonfuls of chicken broth, but man, I wasn't going to not swallow something every single day of my radiation treatments. But I did rely heavily on the peg tube, which has its own side effects. I definitely experienced issues with esophageal sphincter relaxation and things like that. And I've never suffered from a reflux, but you know, just kind of going up and down my esophagus, which was pretty unpleasant. Definitely swelling to my face, my head and neck. You can see in that picture where it looks like I have kind of scales. That's from my mask, because my face and head started swelling so bad. It was like so much pressure to get the mask on. A lot more there. I'd be happy to answer specific questions folks have at the end. And you know, honestly, it was a long time ago. And so I actually think that a lot of my life, even though it's not quite half my life, I feel like, man, my life has really happened since then. Excuse me. I got married. I had proposed to my wife a month before my headaches started. So we got married the following summer. We waited a few years. My daughter was born. She just turned 19 2 days ago. She's a freshman at the University of Cambridge in England, which is amazing. I took on a challenge to celebrate 1 year out of cancer by doing my first triathlon. And that's how I was going to note my anniversary. And this came about, again, a fellow patient. She told me that she had found one thing. And when she does that one thing, she doesn't have cancer. Cancer can't touch her. Cancer can't put a hand on her. And I signed up for this triathlon thinking, man, maybe that's my one thing. And over the next 18 years, that would be a significant part of my physical health journey. I've had the privilege of going to 6 Ironmans, running the Boston Marathon 8 times. It became a family event. That picture of my daughter in the car seat there, that's actually her first outing out of the house, and it was to go to a sprint triathlon with my wife and I. Our vacations kind of centered around this, and most of the time, almost all the time really, I was running those races to raise funds for cancer research, patient services, and survivorship initiatives. So that is really a huge part of my health and wellness journey as a cancer survivor. I've since hung up the shoes, but for about 18 years I did that. The picture down in the lower right, to celebrate 20 years, my son, who's now 15, decided that, excuse me, he was going to raise $20,000 to go to cancer research here at Hollings Cancer Center in Charleston, South Carolina, to celebrate my, sorry, it chokes me up a little bit thinking about him doing that, to celebrate my 20-year cancer survivorship. So that's a bit about my journey, my life as a survivor. There's a lot more to it over the course of 20 years. To talk about a few long-term side effects that I've experienced. I take dental health very seriously. I've been very fortunate. There are some advantages to having cancer young. You know, being almost 50 years old, I think back to what I went through at 27, and I'm like, man, I don't think it would look like that if I went through it now. My body certainly handled it better than I think my body would now, and it certainly recovered better than I think my body would now. The downside to that is anxiety, depression, and the reality of kind of dealing with mortality at an age when it's not appropriate in the human developmental cycle. And that's been a struggle, honestly, over the last really 5-10 years, most of all. And I've relied heavily on a support network, including my therapist, my counselor, my faith, my family, my friends, and my survivorship crew, honestly. And doing things like this is very therapeutic. So thank you again. I have a lot of sinus issues. That would be my primary. I do have less saliva. I was told I'd never eat a sandwich again. I've eaten many sandwiches since then, and I'm very proud of that. But I was told I would never eat a sandwich again. I did have amifostine during my radiation, which was designed to help protect salivary glands and some other structures from certain long-term radiation effects. Most of my issues are on the right side where I received that boost radiation. I still have issues with a new ENT sticking a camera up my nose and not knowing what they're looking at and referring me to an oncologist because they don't feel comfortable not sending me to an oncologist because they've never seen someone whose sinuses look like mine. And I think that gets into the rarity of this disease a bit. My oncologist at Dana-Farber was very clear when he told me that, chances are if you go into any doctor's office, they might see a patient like you once in their career. So if you're walking in, you're probably that one. So being your own advocate and keeping in mind, I don't like to think that I live, based on my experience with cancer, but I always have to keep it in mind when I go to a doctor. I have thinning of my sinuses. I have blood vessels that are coming to the surface. It's some very unpleasant ones in regard to that. I have thinned eardrums. In ENT, I didn't think to bring it up, decided to try and put a tube in my eardrum. That didn't work very well with radiation thinned eardrums, so I have a permanently perforated right eardrum. I have a pocket in my throat from radiation that makes it difficult to swallow. I've developed in the years afterwards, I'm not saying it's necessarily related, but I was diagnosed with Barrett's esophagus and eosinophilic esophagitis, which shrinks the esophagus and makes it even more difficult to swallow because food can get stuck in your esophagus. So if you combine that with some of my other swallowing issues, it's relatively unpleasant. I find it difficult to eat. I have to use a lot of fluid. I have to swallow many times. I have to clear my throat. I have like a wet voice for a period of time after eating. I have a lot of neck spasms still. Even today, I have to do a lot of exercises. This whole thing with Ironman was really my response. Like, you're going to have all these physical issues. And it's like, okay, well, I've got to take care of my body. I'm just looking at my notes here. I'm sorry. I have shrinking, hardening of my carotid artery, a very important thing to monitor, particularly as you get into years into post-radiation for some patients. I would just ask your team about that one. My thyroid is almost non-existent, so I do supplement pretty much a full replacement of thyroid hormones on a daily basis. But mainly these things have become habit. And so one thing I do share oftentimes when I talk to recent survivors or current patients, that maybe a lot of these things like, oh, I've got to do this every day and I've got to do this for my oral hygiene every day. And, I still use a fluoride toothpaste. I don't use trays anymore. I brush more times than most people, all of these things. I like to say that brushing your teeth kind of just becomes like brushing your teeth, right? It just becomes a habit. After 20 years, I kind of have to think about all these things. Like, what are all these side effects? What are all the things that I do to maintain kind of as best I can? They just become part of daily life. And yeah, it takes up a little more time. And sometimes when I list them all out, and I haven't listed them all out here, and I put them on paper, I'm like, wow, yeah, that's a lot more than maybe a lot of people have to do on a daily basis. But, you know, it just becomes part of survivorship. And I think all of us would agree that I'd rather have this as part of survivorship than not have survivorship. So with that, I'll stop sharing and I'll turn it over to Lisa.
So thank you to Dr. Wan and Brad for sharing your insights. And I think we're going to just, in the interest of time, kind of breeze along some of these slides, especially because Dr. McDonald covered a lot of the side effects. But I certainly want to thank everybody for joining us today. I think it's great that we had such a wonderful turnout for our patients and the caregivers. And I'd love to thank the AHNS and the Head and Neck Cancer Alliance. So really, we're just going to do a bird's eye view about some of the side effects, but really, I'm going to enlist the experiences of Dr. Wan and Brad to get us through this.
Hey,
And so,
Lisa,
yes.
I think we're seeing your presentation view.
Okay, I'll swap. How about that?
Perfect, thank you.
Okay, perfect. So Dr. McDonald did a beautiful job covering some of the early side effects of radiation, such as mucositis, sores in the mouth, the dry mouth, the thick mucus, and also the taste changes. And a question to Dr. Wan and Brad, while you were going through your treatment, what medications or over-the-counter products, remedies, were beneficial to you in helping some of these early side effects through treatment?
Yes, excellent question. I don't know if you guys can hear and see me, but I have my video on and my audio on. But as far as the radiation burns to the neck, I used Eucerin cream, Aquaphor. I don't, because of the kidney donation history, I don't take NSAIDs, but I would take Tylenol as needed for pain. Gabapentin was offered to me as well, but quite frankly, I really didn't need it nearly as much as I thought I was going to. I think mostly over-the-counter products were good, and like I mentioned, physical therapy, dry needling, massage was extremely helpful in just mitigating some of the neck spasms and stiffness that I struggled with during radiation. As far as chemo, it got to a point that really Zofran or any antiemetic was simply not helping, and I just had to learn what foods would tend to make it worse. I had to avoid certain smells. A big thing for me was, for whatever reason, the saline flush and the smell of the wipes that they would use to wipe down the chair and the treatment area at when I went to the center for my chair time just provoked significant nausea. So learning my triggers and anticipatory management of what those triggers were was hugely helpful for me.
Dr. McDonald mentioned magic mouthwash. That certainly took me back as far as medications are concerned. I use a lot of gels, oral moisturizers, things like that, pretty early on. Baking soda and salt rinses. That was honestly, it's been 21 years. I don't remember everything that I did at the time.
And really, the importance of eating and swallowing cannot be overstated throughout treatment. And so what we know from the literature is the more you eat, the more you do your prescribed exercises from your speech pathologist, the more likely you are to eat by mouth long term, and then also have reduced rates and dependence of feeding tubes use. So for Dr. Wan and Brad, what were your sources of nutrition and hydration through treatment? And really, how did you stay motivated to continue to eat by mouth? I think, Brad, you talked about how you were never going to go a day without swallowing. And I think that is kind of a great mindset to go through treatment. But certainly, what got you through, or how did you shift to that mindset to get you through the really difficult times through treatment?
Uh, really my family. They, my brother in particular, would line up like various different types of water bottles with different slogans on them and would say, okay, how many of these are you going to drink today? And just wouldn't let me there. You kind of hit a wall where you're just like, I don't want this. I don't want to drink anything. I can't taste anything. And my family just was like not willing to allow me to waste away. So whatever it was that I said, okay, I'll try this today. They made it happen. Whatever that was. Some days it was just something like some crackers is all I could get down, maybe a little broth, water. I stayed away from carbonated beverages that tended to make things more painful and were even harder to get down. Um, so I had extra motivation knowing that I had one kidney and I was on cisplatin, and knowing that if I didn't stay hydrated, that could potentially get worse and continue to get worse. Um, One thing that I would say, it's maybe not directly answering the sources of nutrition, but I learned um, to avoid foods that I actually really, really love during treatment, because if you eat them during treatment, you kind of don't want to have them after. So an example for this is like, I love the Vietnamese soup pho. I loved past tense. And I would try to eat it after um, finishing chemo, and now I can't stand it. So learning to just kind of eat and drink things that are going to sustain you, that are high in nutrition, dense nutrition, smoothies and things like that, and maintain your whatever works for you as far as hydration. As the time goes on, popsicles, things that are frozen that feel cool, that are cool, feel good going down. But really, my family is really what pushed me through and made sure that I got the nutrition and hydration that I needed.
Mhm. In the interest of time, I'll just say yes.
Okay, sounds great. All right, and the saying that folks say that radiation is the gift that keeps on giving. We talked a lot about the early side effects, but unfortunately, radiation does have a lot of long-term side effects. And I was seeing some comments pop up: difficulty opening the mouth, called trismus, also food or liquid coming up through the nose, nasal regurgitation are really quite common. So meeting with your speech pathologist for an evaluation is going to be really imperative to catch some of this dysfunction. And back to Brad and Dr. Wan, what long-term side effects do you continue to experience, and how do you manage them? And if you haven't developed those side effects, what do you do on a daily basis to help stave those off from development in the future?
I might jump on this one first. The long-term side effect that I feel like I've avoided somehow, and mainly dental effects of radiation. First of all, if you're about to go through, don't skip your preparatory dental visit. I had some precautionary fillings put in and things like that I think have made a huge difference over the long haul. But really, oral care, oral care, oral care. It's not just brushing and flossing, it's rinsing, it's using the right products, the right toothpaste, trying to keep your mouth, moist, all of these things. I really can't stress that enough. I've talked to so many patients who haven't taken care of that, and it's been really negative. For me, like I said, long-term side effects have to do with saliva, swallowing, mostly eating, and radiation damage. I am told, I don't know, I'm not the radiologist, that keeps on giving, as far as thinning of membranes, and so then it becomes like sinus rinses every day. Sometimes I do forget, but just trying to keep things as moist and healthy as possible. Yeah, that's the main thing.
Um, For me, really the physical manifestation as far as side effects have been the neck pain and neck spasm. It in a way affected my posture because when it's tense, I kind of hold my shoulders up high. But again, massage, dry needling has helped. I think a side effect that you may not think of is really the health. I developed severe health anxiety that I have to continue to manage with, every time I have to get tests or go to a doctor visit that's completely unrelated. And just managing that by, developing and strengthening coping skills, working through therapy and, just time. I think tincture of time is the best way to manage that. Support groups, doing things like this, engaging, being open, talking with my friends who probably by now could tell you, could probably write a lecture on nasopharyngeal carcinoma in my family. So the health anxiety has been probably the most significant side effect that I've experienced long term.
And really going over all of these side effects is not to scare any patient or caregiver, but I really feel that knowing and being informed is really empowerment throughout your treatments. And with these side effects, there are a number of options, both therapeutic and surgical, that can help improve swallowing function. I saw one comment about nasal reflux. There's a lot of compensatory strategies, maybe prosthetics, and even an injection of a little bit of filler to the posterior pharyngeal wall to help that, trismus, so jaw exercises, swallowing exercises, esophageal dilations. And really, because this can be a long-term game, kind of seeking care along the continuum of your journey and your treatment is really imperative. So just to finally wrap it up with Brad and Dr. Wan, is there anything you wish your treatment team did differently during your journey? And what words of wisdom do you have for patients as they embark their own cancer journey?
Gosh, I feel terrible. I finding anything to say that I wish my treatment team did different. They were so good to me. Um, I think if there was anything, I would say with my medication, my medical oncologist and my radiation oncologist, they were at two separate centers. So um, I wish that maybe my medical oncologist had maybe uh, connected with my radiation oncologist earlier in treatment because he had more experience with treating NPC, and that may have avoided some of the quite frankly, terror that I initially experienced upon receiving my diagnosis because he had to consult people overseas for recommendations as he wasn't quite sure what to do. So that was a little anxiety provoking, especially knowing what I know as a physician. Sometimes you know too much. Words of wisdom that I have for patients in their cancer journey is to, this is absolutely beatable. This NPC is a treatable, beatable disease. You will find it sounds very cliche and very woo-woo to say it, especially if you're new in your diagnosis. But as you progress through treatment, you will find that strength inside of you, as well as the universe, whatever your spiritual belief is, God will send to you the things and the people and the resources that you need to get you through. And I am a firm believer in that because I've seen that happen in my journey, as well as the journey of others that were experiencing this at the same time as me. I would say, really lean on your faith, your resources, your support system, and give yourself grace. Allow yourself those days where you're like, the best thing I can do today is get up and go to treatment, and I'm going to come right back and I'm going to get in bed, and that's okay.
Mm-hmm. Yeah.
Which is
Beautifully
particularly
said.
hard. I had a daughter who was not yet 2 years old, so I suffered with a lot of guilt, with her wanting to play and interact with me, and I just couldn't do it. But I had to get into the mindset that if I don't get through this and heal myself and allow myself to be healed, I won't be the best, healthiest version of myself to parent her on the other side of this.
Well, thank you for sharing that.
Mhm. I would echo what Michelle said, and almost all of the things, except for the things that were particular to her experience. For me, treatment at the time, the amount of radiation, my radiologist did not want to give me that much radiation. He thought it was too dangerous for someone at 27. That's the only thing that comes to mind. Is I just wish I had been through a more standardized protocol. I think they were writing it as they were doing it with me. But I'm not complaining about that because I'm here. And what words of wisdom, I would just say there's a difference between asking questions and questioning. And I think sometimes we don't ask questions because we don't want to question. But asking questions, understanding why, are there other options? It helps us, I believe, with motivation if we know why we're doing things. Like, why do I have to do all this stuff around my treatment and for treatment and things? I believe that that's what has served me over the last 20 years is I asked so many questions. So then when I would go talk to doctors who had never seen someone like me, I had answers to bring along with me. And I think that would be my biggest piece of advice, if I could say that. Yeah.
Excellent. You guys are both such an inspiration. Thank you for sharing your experience. Appreciate that. So I guess I'll toss it over to Dr. Kong.
Thank you. And I'm really touched by all these inspirational talks you guys have given. So thank you very much for sharing that experience. So I'm going to talk about the options after recurrence. So this is a little bit depressing topic, but I do want to emphasize that we do have options and there are good treatments evolving. So what if my cancer comes back? Majority of recurrences, about 50 to 60%, happen within the first 2 years. So if you are out of that window, then probably you're going to be safe. Although, we do see late recurrences from the end of the treatment, it's not that common. The rule of the thumb is that if the recurrence is surgically resectable, surgery would be the treatment of choice. And this is usually the situation that if the recurrence happens in the neck lymph nodes, and if surgery is not possible, but if radiation is feasible and safe, then we can consider doing radiation again plus minus chemotherapy. Otherwise, the options are limited to systemic therapy, which means chemotherapy or immunotherapy. So if you end up being in that bucket, what to expect from systemic therapy is that we do use it as a palliative intent. So chemotherapy or immunotherapy is not intended to cure you. However, with use of immunotherapy, we tend to see longer duration of response. So a lot of people can enjoy the benefit for a longer period of time compared to the time that we only had chemotherapy as an option. Obviously, you should weigh risk versus benefit, and chemotherapy does come with some side effects, as you may have experienced with primary treatment, but it can induce response in a very short period of time, and reducing the disease burden can be very important, especially when you start the treatment. Standard treatment options, usually we use first-line chemotherapy and immunotherapy as a combination. And if you progress or if the first treatment doesn't work, then we go on to second-line treatment. And there are many options, either immunotherapy, chemotherapy, or clinical trials. If we go into more details on this, the FDA-approved first-line option is gemcitabine, cisplatin, or carboplatin, and toripalimab. And this regimen had been tested in large phase 3 randomized trial and had shown to improve overall survival over previous standard of care gemcitabine and cisplatin, the chemotherapy alone. So now this triple combination with immunotherapy is the first treatment option. If this doesn't work, then you can use other treatment. For some reason, if the immune therapy was not used in the first-line treatment, toripalimab is approved in second line. So if a patient who had progressed on chemotherapy alone, toripalimab had shown to improve overall survival. Other immune checkpoint inhibitors, other immune therapies like tislelizumab, pembrolizumab can be used in this setting and has been tested in other small clinical trials, but these immune therapies are not approved by FDA. But may be available depending on where you're treated. Single agent chemotherapies can be used. We generally use things like capecitabine or docetaxel in this setting. They may or may not work, but it can be useful to earn some time. And if there's a clinical trial option, I would strongly encourage you to consider that as an option, because that's how we develop new drugs. And the current standard of care, toripalimab, has been developed through clinical trials. So if there is any new drug on the horizon, that might be the best option that you have. And in particular for nasopharynx cancers, there are a few promising agents. So one is being tested in Stanford using a drug that targets EBV, which is the main driver for nasopharynx cancer. So that could be something that you could consider. Well, in wrapping up, the things that you have to think about in getting treatment for recurrent nasopharynx cancer is that nasopharynx cancer is a rare disease in North America, and not all practices or providers are familiar with this disease. And you should consider access to clinical trials. And again, it's not available to all sites. And another important thing to emphasize is that I didn't really talk detail about the biomarkers, but we do use a lot of biomarkers to assess possible treatment options. And that includes next generation sequencing to look for genomic mutations or alterations, or EBV virus testing that can be done through through the blood test. And EBV blood test has been shown to be prognostic, which means that if you have EBV level higher than certain threshold, then it has been shown that your prognosis will be worse than people who had lower EBV, especially in the beginning of the treatment. And it's less proven in disease monitoring setting, but we do use it as a monitoring tool for patients getting treatment. So considering this all, please consider getting care at a high volume academic center. Always the treatment volume is important, and the providers will have more experience in treating this disease and is more likely to have access to newer treatments, newer biomarkers, and clinical trials. And I would be happy to answer any questions. Thank you.
Thank you, Dr. Kang. It's so great to hear that clinical trials are continuing so that we can find more options for patients with cancer that comes back. This concludes the speaker portion of our session. We have probably maybe a few minutes for Q&A for those who can stay. There were a lot of questions about EBV titers and whether or not it should be standard to check EBV titers throughout treatment and in surveillance. Dr. Kang or Dr. McDonald, do you want to speak anything about that?
Yeah, so most of those EBV tests were studied in Hong Kong or China. And what we know for sure is that pre-treatment EBV level is very important in determining the outcome. And there are several studies to look at the EBV level in the middle of the treatment. And if the changes of EBV level, if the EBV drops after starting the treatment, that also leads to the better outcome. But it is less studied to use it as a monitoring tool or surveillance tool after finishing the treatment. So there's no definite data on that, but in my experience, it's a very sensitive marker depending on what primer you use. So I generally use it as a surveillance tool for patients on monitoring.
Okay. There are also some questions about more frequent dental follow-up for a lot of patients. Patients are asking if they need to do more frequent dental follow-up. Lisa, do you have anything you could add about that?
Yeah, it's not uncommon that patients do see their dentist more routinely. I have some patients that go every 4 months instead of every 6 months, depending on what their need is. And certainly if they're going to require any dental extractions, that is all collaborated with the head and neck team as well, and as radiation oncologists to mitigate any fractures that could happen with the jaw. So certainly kind of upfront collaborative care is needed before any big dental interventions.
Great. And then there were, actually a few questions about VPI, which is velopharyngeal insufficiency. That's when after radiation treatment, the tissues shrink so much over the long term that the tissues in the back of the nose, they don't do a good job separating the nose from the oral cavity from the mouth, from the nose. Dr. McDonald, do you want to add anything about possible options? I have some things I could add too.
I'll let you take the lead on that, Dr. Lin.
Well, it's unfortunate, and it's not complete uncommon side effect, long-term side effect of radiation. And there are palatal obturators that can be done, which is where a prosthesis, kind of like a denture, is put in the mouth, and that can sometimes separate the two areas. But as we get over time, as we have more and more patients with disease, and we get more advanced in our head and neck reconstructive techniques, high volume reconstructive centers should be able to offer some sort of surgery for this. The results are not always perfect, but whereas I think in the past, there were times where people felt like nothing could be done, there are things that can be done for this. Okay, so that concludes our session today. Okay. Doing this right. I wanted to have my last slide. I had some patient resources I was going to share, but I won't share in the interest of time. But I encourage you to go onto the American Head and Neck Society websites and the Head and Neck Cancer Alliance websites to get more information, more support groups. There's peer-to-peer mentorship programs available. And lastly, I really want to thank Coherus for its sponsorship, and thank you to all our speakers and the audience for such a lively chat. I had a wonderful time, and it was such a pleasure for me to hear everyone's stories. Thank you.